Harrow, excuse me, getting that correctly. And if you are new to participating to our ECHO, just a brief description of our format. We do begin each session with some brief introductions. Since we do have a smaller group today, we can actually take time and do personal introductions here in a moment. We then have a presentation by our guest speaker. And then if anyone has a question about a case that they have with the patient, or general questions and answers, we then go into that as well. And so what I'm going to do right now, we are doing some, for those of you who have been with us before, we are starting something a little differently. We are starting to use a pre and a post test so we can see how people's knowledge is improving with these sessions. So I'm going to ask Jenny if she could bring up the pre-test on your screen. It may take a moment for that to come up.
It came up on my screen.
It did come up. Okay. Probably because I'm the one that input it into the system.
Yeah, as a host, it didn't. Yeah.
Right.
Thank you. So has everyone had a chance to complete that?
Yes, everyone's
Okay.
responded.
Okay, thank you, Jenny. Thank you. What we'll do next, we will do some real brief introductions. Just really, tell us who you are, just, briefly what your position is, and what organization that you are from. I can start. My name is Mary Ellen Kahn. I'm an assistant director with Cancer Prevention and Control at the WVU Cancer Institute, and I am also the program director for our state's Comprehensive Cancer Control Grant, which helps to support the Mountains of Hope Cancer Coalition, which is one of our sponsors for today. So I will turn it over and I will popcorn it to Susan.
Hi, I'm Susan Eason. I work with WVU's Cancer Institute as well, and Cancer Prevention and Control. I work with primary care practices across the state and focus mostly on colorectal cancer screening.
I can go next. Oh, sorry.
Go ahead.
That's all right. I'm Ruben. I'm a licensed clinical psychologist in the Department of Family Medicine at WVU. My training background is in clinical health psychology and have worked in the past with patients with cancer diagnoses and behavioral health changes with chronic illnesses is something I'm very passionate about, clinically wise and research wise. So I'm very excited to be here with you all to talk to you today.
Thank you. And Valerie.
Sorry, I was muted. Can you hear me?
Yes.
Okay. My name is Valerie. I'm a nurse practitioner at the Wheeling Cancer Center. I mostly cover the infusion room, so that's what I do here.
Welcome. And Courtney?
Hi, I'm Courtney. I work in the Office of Cancer Prevention and Control as the office administrator.
And Jenny?
Hi, I'm Jenny Austin. I am the director of mobile cancer screening at the WVU Cancer Institute. We have 2 units, one for mobile mammography and one for mobile lung cancer screening. I'm also helping out with this and have been involved with Mountains of Hope since 2008.
Yeah, thank you. Welcome, everyone. Just some brief reminders about our session. If you do feel comfortable doing so and want to turn on your camera, we encourage you to do that. We do ask that you keep your microphone muted during the presentation. When we get later to the question and answer segment, You can either feel free to take yourself off of mute to ask a question directly, or you can type it in the chat, whichever you're more comfortable in doing. As you saw, our session is recorded. We do record those. They do go up on, we have a private YouTube channel for our ECHO sessions, so that participants or anyone who has been at some of our previous ECHOs can access those if they were not able to join us for today. Later on, if you do have a question regarding a patient case, we just ask you, please to not disclose any PHI information. And then also, we do provide continuing education credits for these sessions. We are approved for one AMA PRA Category 1 credit, and then we are also approved for 1.2 contact hours for nursing. So if you are wanting to get CE credit for today and you've not already done that with us, I'm going to put in the chat a link. The CE office, they do have a specific registration that is specific to our ECHO. So if you've not requested credits from us before, just please click that link and fill it out. That way we'll have all of your information and your license number, so we can get you credited accordingly. So I will now turn it over to our speaker and we can get started.
Fantastic. Thank you again for having me today. So the title of our talk today is Behavioral and Lifestyle Changes Following a Cancer Diagnosis. Next slide, please. Then I have no disclosures or conflicts of interest. So objectives for today is by the end of the presentation, I'm hoping that all of you here in the audience will be able to identify a level of behavioral and mental health care needed for patients with a new diagnosis of cancer, be familiar with some evidence-based interventions that promote the well-being of patients with a diagnosis of cancer, and lastly, understand the importance of motivational interviewing in promoting engagement in health-promoting behaviors following a diagnosis of cancer. So one of the things that I think is important to talk about is, what do we know in terms of cancer and all the various forms of cancer and psychosocial factors? In the literature investigating these two factors, we know that there's not necessarily any evidence to suggest that, for example, stress causes cancer, but there's a lot of research that is finding evidence to suggest that stress processes are associated with the onset and the course of cancer. As an example, we know that patients who are having concerns with depression, anxiety, other forms of mental health disorders have increased risk for developing certain kinds of cancers. And also there's a link between these mental health diagnoses and the progression of cancer. Mechanisms that have been found that promote those associations are related to the HPA sympathetic stress systems. Some of these are believed to impact immune functioning, which then may, of course, have an impact on the course of the cancer. So being able to address these factors is critical. And I think in hearing from the audience's interest, sometimes in addressing these factors over the course of one's lifetime may be critical in the prevention of cancer diagnoses. I think we still need more longitudinal research to look into those factors, but we do know that amongst populations who receive the diagnosis of cancer, being able to receive psychosocial support that is meeting their needs can be very helpful and promote recovery. Next slide, please. So here what you'll see is a graph that I think, or a diagram that will capture a very important thing to consider when thinking about what level of care a patient needs. Because receiving a cancer diagnosis is going to be received differently by different people based on their personality factors, based on where they are in their life, receiving the diagnosis at a younger age versus an older age may be something that impacts that. Social support networks, prior experiences with chronic illnesses, in general, who we are is going to impact how we're going to respond to stress. Sometimes when thinking about how to best promote one's ability to manage stress, such as a cancer diagnosis, we have sometimes a tendency to say we got to throw everything at someone. We got to throw every possible intervention to try to help someone when maybe that may not necessarily be needed. And so one thing I encourage you to think about is to assess where your patient is in terms of their response to the cancer diagnosis. As you see here in the diagram, some people may start off with understandable, just normative kind of reactions where there may be an uptick in anxiety following the diagnosis, there may be some concerns, but may not necessarily be something that needs to be fully addressed. Whereas as you go down the diagram, you start getting into more of the adjustment disorder category where someone is needing a little bit more support, needing a little bit more guidance, needing maybe perhaps involvement in some kind of group therapy program that your institution may be able to refer patients to. As you get further down in that continuum, you may find that a patient is really demonstrating some significant challenges in response to a cancer diagnosis. And so that would warrant a bit more individualized assessment by someone that can really assess what's going on with the patient and then have that assessment inform the kinds of interventions that would be needed, whether they are on the behavioral health side of thing, or maybe also needing more pharmacological treatment to address someone's response to a cancer diagnosis. It's important to note that if a patient already has, for example, a prior history of mental health challenges, we can expect that that patient is going to be responding in a different way versus someone who doesn't have that history. And so all of those considerations would be critical. And so early and consistent assessment of how a patient is doing in terms of their emotional response to the diagnosis and how they're doing as, for example, treatment is progressing to address the cancer is something that I would highly recommend. Next slide, please. Here you see another important diagram that I want to highlight for you all. One of the things that is critical is to think about what are we trying to target when we're trying to provide psychosocial treatment to patients who have just been diagnosed with cancer. A lot of times what you're trying to work on is the side effects that are related to the treatment of cancer, whether that is chemotherapy or recovering from a surgery. So those factors may be impacting the day-to-day quality of life of a patient. So those may be areas to address. Other things that are maybe coming up is how to build a sense of self-efficacy, this idea that a patient can feel like they can do something to promote their well-being and to do something to be able to impact some element of their life. Patients often with a diagnosis of cancer feel like they are powerless. They feel like there's nothing I can do now that I've been diagnosed with cancer. And so building up that sense that they can do something may be very, very helpful. There also may be some work to do in terms of building up someone's social support system and including yourselves as one of those members of someone's social support system following a cancer diagnosis. So the interventions then are going to be targeting one's mood, one's stress responses, trying to promote ability to adhere to elements of what may be a very challenging cancer treatment plan, trying to improve engagement in other activities that are going to promote the well-being of a patient. And I'll talk a little bit about some of these areas that I think could be very helpful, such as sleep. And so what we're looking for from these interventions is to see if we can improve overall the well-being of a patient, improve health outcomes, see if that can improve a patient's ability to best communicate with his healthcare team, or his or her healthcare team. And so all of those would be things that we're hoping to get from these interventions. At the bottom part of the diagram, you see that there are treatment moderators, basically factors that are going to impact how these interventions will ultimately be or not be helpful to a patient. And so this is an important consideration. As you see, some of those factors are socioeconomic status, age, ethnicity, culture, personality, premorbid functioning. All of those factors are going to influence how a patient's going to respond to any of these attempts to help him or her. One of those that I think is really important to think about, especially in the state of West Virginia, is SES, health literacy, understanding that if we're talking about a patient that lives in an area that is very rural and we're trying to help him or her, and they may not have transportation, for example, to get up here to Morgantown, those are factors that we would have to consider when trying to address a patient. So we're trying to provide them with any kind of mental behavioral health interventions. We have to think about where they're located, what situation they find themselves in, and taking those factors into consideration. I was sort of trying to help a patient who may be living in that kind of a context. So understanding that these interventions have to be flexible in their implementation is critical. Next slide, please. All right, so one thing that I want to encourage the audience to think about is being able to assess further what are the stress processes and the factors that are impacting any given patient after a diagnosis of cancer. As I alluded to earlier, sometimes when we hear someone is stressed, someone is having a hard time with something stressful, we think, absolutely, we gotta get you to meditate. We gotta help you be able to do this or that intervention. But one thing that I think is very helpful is to think about what is the nature of someone's stress in their life. And this is a diagram that kind of highlights 4 different stress processes that I think are worth looking into when trying to figure out how to best help a patient. So the first process is stress exposure. And so that entails what is it that you are being exposed to that is stressful. So we're thinking daily hassles. That would include things like I'm running, late, or I've got a flat tire, or, I'm having this issue with like internet connectivity at home, whatever it may be. You also have major life events, which a cancer diagnosis would certainly be one of those. But we're thinking also things like, health situations with other family members, stresses at job, big additions to the family like a birth or a death, so we're thinking about those factors. The other parts that we also look at is time management difficulties. That may be itself generating a lot of stress for a patient. Other things that we tend to see are interpersonal problems that a patient may be having. Worry and rumination are also in this category because when we're worrying, which is thinking about things that are going to happen in the future or reliving things that have happened in the past, those cognitive processes elicit a lot of the same reactivity within us as a more identifiable stressor, such as like a flat tire. And so if someone's having a lot of concerns with worrying or thinking about things that have happened in the past, that may also be a target to address. The other parts you see there is one's reactivity to a stressor. So once you've been exposed to a stressor, how are you responding on a physical, emotional, and cognitive level? And how then you can recover back to those baseline levels of physiology and how you are doing emotionally. That last part you see there, stress restoration, is about how are we then able to recover from a long day of a lot of stress exposure, a lot of wear and tear that each of us go through. We need to find a way to literally repair our body from the wear and tear. So we're talking cellular level reparation. And then also, what are we doing to promote our emotional well-being after a long day? And one of those processes is also sleep. So all of those different areas may be things that we want to consider. So being able to assess for any given patient, what is the nature of the stress? What are the areas that you feel like you're struggling can really help us be more targeted and more specific with how we help any of our patients. Next slide, please. For it. Thank you. Another thing that I feel like is important when we're beginning to assess where our patient is feeling after a cancer diagnosis is, how do we respond to the patient in the room? And I think being able to put aside the medical chart or any other kind of obligation and say, I'm going to look at my patient in the eye, I'm going to sit down and really square my shoulders to this patient so that I can really read the patient and really be there in that moment is going to be important. Providing emotional validation as appropriate, making sure that you use reflective statements to really have a patient see that you're really engaging with him or her during a very vulnerable time in their lives is very important. When you're trying to figure out how are they responding to the cancer diagnosis, what are some of the stressors that they're having in their lives, being able to ask a bit more about the stressor. Tell me more about it. Have you ever had a similar kind of situation? So that you can help them understand that, you know, maybe there's a way that you can help them, and you want to be able to better understand how they are processing a particular stressor in their life, because then that will inform how you can best help them. Next slide, please. So now I want to get more into the intervention side of things. And the first one that I want to talk about is meditation. This is a kind of an intervention that has really gained a lot of popularity, especially in the last 10, 20 years. And there's a little bit of some, in my opinion, misunderstandings about what meditation is. Meditation is an intervention that is a very active cognitive process. What you're doing is, for some period of time, you are going to be observing what is going on through the five senses and what is going on emotionally, what is going on mentally in terms of your thoughts. And what you're doing is you're moving your attention to each of these potential elements of any given moment when you're practicing meditation. So it's very active. A lot of times people tell me meditation is something that I think is supposed to help with me being able to relax. And some people do find it relaxing. Some people even kind of doze off when they're meditating. But we know from the sort of neuroscience literature that what it really does is it activates the prefrontal cortex. And so it's a very active process. Now, the utility of it is that when you're practicing meditation, it's really activating that frontal cortex part of the brain. And that is really, really helpful to impacting all the other stress processes in the body, including one's heart. So while you're doing it, you're actively promoting your stress ability in that moment. The other part is that as you're practicing meditation and you are able to acknowledge, for example, difficult emotions, challenging thought processes, and instead of having a response to those emotions or those thoughts, you're able to notice that they're there and not have a response to them and accept that they're part of the moment there. You can apply that same technique to your daily life and say, when I am confronted with difficult emotions, especially after cancer diagnosis, I can sit with that emotion a little bit. I don't have to have an immediate response to that emotion. If we're able to spread the gap between recognizing emotion and figuring out how we want to respond to that emotion, increasing that gap allows us to think about how we can best respond to that emotion. And so as patients are practicing meditation, they're practicing how they can be comfortable with emotions, thoughts like worry that are maybe really troubling, and say, I recognize it. How do I best want to respond to it? And that is what meditation really promotes for all of us. And so that is why I think it's an intervention that can be very helpful. So when you have a patient that's having challenges with worrying, with rumination, difficult emotions, this could be the kind of intervention that would be very helpful. Next slide, please. I just wanted to highlight a few different resources here that I encourage patients to use if they're interested in getting started with meditation. So there are wonderful videos online. Jon Kabat-Zinn is kind of the pioneer that brought meditation over to the West. I tell people, if you have a Netflix account, there is a Headspace channel. It's a very popular application that is available. And there's a channel for it on Netflix. So if you're ever at all interested in meditation and want to give it a try, if you have a Netflix account, get the most out of that $10 or $12 monthly fee that you're having to pay for. There's other sources like Calm that's very popular. There are also recordings that are available through the Dartmouth University Counseling Center website, and they have a lot of really good recordings for deep breathing, for guided imagery, which has been shown to be very helpful with patients that are undergoing challenging treatments for cancer. There's progressive muscle relaxation that can be very helpful for anxiety management, and also meditation recordings. And so there are some resources out there that if our patients have an internet connection, they're going to have access to. So highly recommend that if a patient is wanting to go down this route, that they're given resources that are going to be accessible to them. And if they want to, of course, they can get going with an application, but not necessary in many cases here. Next slide, please. One other thing that I find very helpful when we're thinking about adjusting to a diagnosis of cancer is, how do we communicate both with our healthcare team and also our loved ones? And I'm a big proponent of promoting assertive communication with all of my patients, but especially following a diagnosis that is chronic or something like cancer. And assertive communication, you can read here the definition, but what it really is trying to do is promote a patient's ability to be able to express their emotions and do so in a way where they can feel free to do so, and they can directly tie them to someone else's behavior instead of just sort of expressing the emotions and letting it sort of all explode out at once. And the goal isn't one to try to get someone to help you do what you want to do, or this isn't one of those methods that's this is what you do to get people to do what you want them to do. This is really about actually promoting equality in our relationships. Next slide, please. So when we're thinking about how do we then help our cancer diagnosis patients be able to rally support around them, important thing is to identify those people, but once they're there is, how do you help a patient best use that social support system? So sometimes patients will say, look, I've got all these people who are sending me, all these cards and are asking to do this and are doing that. And all of those are really well-intentioned things that people do to rally around someone who's just been diagnosed with cancer, but it may not necessarily be what they're looking for. And so giving them some resources to best assertively communicate themselves, I think it's very helpful. So just as an example, one thing that I encourage people to do is to use quote unquote I statements. And so that is where you say, I feel this, whatever your emotion is, and you tie it directly to someone's behavior versus making more of a personal attack about why you're feeling a certain way. So as an example, one can say, I feel hurt when you're spending a lot of time on your phone during dinner. That is going to be much better received if you, instead of saying, I feel hurt because you always do this and you always do that and you always do this, then someone is going to more likely respond in a defensive way. And so giving someone a way to best express how they're feeling to their healthcare team and to their loved ones is going to be critical, because sometimes that's what's causing stress for a patient with a diagnosis of cancer. Next slide, please. So here's a resource that I find incredibly helpful. One of the books that I recommend the most to my patients. It's called Your Perfect Right. It's been published for quite some time, more than 50 years. And it's a book that offers a lot of really good tools to help a patient be able to develop assertive communication skills. Assertive communication being not being passive about how you express yourself, not being aggressive, but trying to thread the needle, trying to express yourself in a way where you're not stepping on another person's toes, but you're also expressing how you're feeling and what you really want. And so this could be very critical to, again, being able to get the most out of one's social support system following a cancer diagnosis. Next slide, please. So critical thing, again, I've alluded to it, is social support is very, very helpful in a cancer diagnosis. And sometimes it's because of the tangible things that social support can do for us, such as being able to get a ride to the clinic or to the hospital. And so that could be very important. Or receiving just that emotional support and having someone that you just want to spend an evening with, cooking something and watching a movie. And so just having that warmth, that comfort is going to be really critical. And one thing that I've found that patients really benefit from is when healthcare team members say, I want you to really surround yourself by the people that are supporting you. And by the way, I want to be one of those people. I want to include myself as a member of that social support system. So you make sure that when you think of social support, you know that I've got your back. And so that can be really, really powerful as well. Next slide, please. Big thing that we know in the literature, which I found fascinating, is that sometimes it's not just that we need that social support in the moment, but we know that it can be very beneficial to perceive, to know that we have social support. Like, as an example, my mom is in California, I'm here in West Virginia, but every day I know my mama loves me. And she's out there in California, and I know she's sending me, her best wishes. And just knowing that I have that support of my mother is critical, even though we're not even in the same state. And so sometimes getting a patient to reflect on who does support them can be just as powerful as the in-person kind of more tangible support that they can receive. Next slide, please. I do want to talk about health behaviors as well, things that you may be able to target with your patient, things that can help with just the recovery from maybe a grueling day of chemotherapy, and things that are going to promote their health in general. And so the three areas that I would encourage you all to think about are sleep, exercise, and nutrition. As you're coming up with some plans to address each of these, I encourage you all to document them and say, yeah, a patient said that they're going to try to be on the treadmill for once a week for 30 minutes. That's going to be the first goal that they're going to try to aim for. Make sure you document it and make sure you touch base with that patient again next time, and they'll really respond to knowing that you have that relationship with them and that you're going to check in on these very important factors. Next slide, please. First one that I want to briefly talk about is CBT for insomnia. And so this is the evidence-based treatment for people who are having challenges with sleep. And we know that following a diagnosis of cancer, a patient may be having issues falling asleep, maybe as they're recovering from a surgery or because of the wear and tear of some kind of treatment plan. So being able to promote one's ability to get good sleep is critical. Beyond kind of getting more into the whole protocol and how it would look like, things that I feel like can be very helpful to encourage a patient to do would be stimulus control. So next slide, please. So this entails making sure that a patient is only spending time in bed sleeping. And so if they're having a hard time at night because they're worrying, and that is taking place at night, you want to make sure that if it's been 10 to 15 minutes and they're not falling asleep, that they get out of bed. I encourage them to do what I call create a little nest, like somewhere in your living room where you can go and just do some light reading or any other kind of light activity. And once you start to feel sleepy, which is really having a hard time keeping your eyes open, then that's when you want to go back to your bed. Essentially, you want to make sure that a patient is not forcing sleep. You want them to be in bed only when they're sleeping. And importantly, it may not always be that you need to be going to bed at a set time. You need to be going to bed when you're actually feeling sleepy. Sometimes less is more. If a patient is able to get less hours of sleep, but those are really good hours of sleep where they're really falling into those deep stages that promote restoration, that may be better than having kind of more fragmented sleep. And so you want them to be consistent with their sleep window, go to bed when they're sleepy, and to not force sleep. Next slide, please. Additional things that I feel like could be really helpful is just promoting a good sleep environment. And I know you all probably have heard about this before, but making sure that as best as possible, that environment is cool, it's dark, you're not doing a lot of stimulating things before going to bed. You want to have essentially a little bit of routine that is priming your body to relax. Next slide, please. I do want to briefly talk to you all about cancer and executive functioning. It's a well-documented relationship, and executive functioning is referring to the higher order neurocognitive processes that allow us to generate and follow through with plans. It involves primarily the prefrontal cortex, and it's kind of the cognitive functions that make us who we are as humans, and that they allow us to generate these novel plans, follow through with them, and be able to come up with more innovative ways to respond to what's in front of us. And we know that that's one of the cognitive functions that begins to suffer, especially during cancer treatment, in particular with chemotherapy. Experiences of pain can further tax those abilities. And so being cognizant of those is going to be really important. Next slide, please. Recommendations that I would have for a team that is working with someone who may be having some of these challenges is to really take those into consideration in terms of your treatment recommendations. So if there's a protocol, for example, for pharmacological interventions that is requiring our patient to take multiple medications over the course of the day, and so there's a lot that they're having to manage, and they're having some problems with their executive functions, it'd be really helpful to talk about maybe having someone that can support them to adhere to that treatment plan, or using alarms on their phone, or other ways that they can have external reminders to make sure that they're adhering to some of these recommendations. So it may get to the point where a full neuropsychological evaluation is warranted, but taking those factors into consideration with your treatment recommendations would be really helpful for this population. Next slide, please. The last part that I want to just talk about is the utility of being able to frame each of these interventions, whether it's improving sleep, improving communication skills, improving engagement in exercise, whatever it may be, through a motivational interviewing kind of framework. And motivational interviewing is a person-centered approach that is aiming to help patients be able to work with the ambivalence that they may be experiencing. Not everybody's going to be ready to go to take every one of our recommendations, but being able to talk to a patient about why they would personally want to make a change, I think can be very, very helpful, so that they're not feeling like they're being told they need to do more of this, they need to do more do of that, but to say, why would you want to make these changes to promote your overall well-being? Is it because of your doctor telling you, or because if you make these changes, they're going to be really helpful in something that you want to accomplish or see in your life? And so really highlighting and working through that and making it come to the forefront can be really helpful, so a patient can follow through with any of the recommendations that you're encouraging them to make. Next slide, please. So my go-to is to just ask a patient, hey, what would motivate you to want to make this change on a personal level? And that could really spur a very helpful conversation, like, hey, I would want to do this because I want to promote my health and and do everything I can that I can control because I still want to be here for X, Y, or Z individuals. And so just making it a bit more personal can help a lot. Next slide, please. Just some of the tools that you can use. You can always help them rate like the level of importance, how confident they are, and kind of have them be on a scale of 1 to 10. Next slide, please. So if they say, for example, like a 2, that's not very high on the scale. Ask them, next slide, why not a 0? So you move down on that scale, and what that is going to do is elicit what we call change talk. They will be able to talk about, well, it's not a 0 because this, and that. And so what you're trying to do is have the patient themselves vocalize why they would want to make a change versus you trying to persuade them to make the change themselves. Next slide. So the whole big picture is, before you try to get going with any of these health behavior changes, you want to make sure that a patient understands exactly why they would want to make the change before you get to the how. Next slide. Once we get to, yes, I'm on board with making a change, I want to improve my sleep or my exercise or my nutrition, then at that point, as I tell patients, we're just limited to both you and I's imagination. Then we can start to think about the nitty-gritty ways that we can begin to set up a very specific goal, a goal that we can track. Let's start small and build from there. But you don't want to get to the goal setting side of things until you really solidify with a patient why they would want to make a change. And last slide, I think, just has my contact information. So I'll open it up to any questions that the audience may have.
And also, if you don't want to take yourself off mute to ask a question, you can always type the question in the chat as well. And real briefly, I'll just mention, we did have some folks who joined us after we started. So we will be sharing the slides from today. So if you came on after we got started, you'll have all of today's information.
Thank you very much for your presentation. I really appreciated it and found it very valuable. I just have a question. You made reference to the fact of some of the stressors for patients on having to travel or come to Morgantown, that sort of thing.
Yeah.
What type of telehealth opportunities do you provide for counseling to patients who are a pretty far distance from the center?
Yeah, so in my department in family medicine, one of the probably good things that came from COVID was we had to respond to the need of just the situation with social distancing, that we really overnight had to just implement telehealth, and that is still there. We offer it pretty routinely. Like today, I do all of my sessions through telehealth, and that is really helpful for our patients that are an hour, 2, 3 hours away from Morgantown. And so we do offer those services. I think hopefully insurances continue to accept those ways of providing therapy. And I think if they do, and we continue to receive support from our leadership, we should be able to continue to provide that form of treatment. It's been there for a long time, especially in the VA system. And I think that we are which is why we still have the ability to see people in person, but certainly telehealth, telephone exclusively. We have to think outside the box, and be flexible. And so at least within our department, and I know some of our folks that provide these services at Chestnut Ridge, I believe everybody's being open-minded and continuing to offer that as an option.
Let me ask one more question. That's great that you provide that. And what is you are very experienced with cancer patients. What is the awareness of primary care practices around the state of your expertise and their ability to refer to you for their primary care patients who've had maybe a diagnosis in the past and may need additional services? What is your awareness of primary care practices awareness for referral?
I can speak more to the department that I'm in. I think in general, other departments that I've been in other states, there tends to be more of a referral to us once a patient is on a really, really bad situation. Like we have a cancer diagnosis and a lot of other stressors, and they're very depressed, and maybe there's some concerns for safety. We get more of those patients where I think that a little bit up in the continuum that I talked about would be great to address them at that level before it becomes more severe. I think that when it comes to other factors that we can help with, for example, more of like the exercise goal setting, improving sleep, which we can very much do. I don't think that's always at the forefront of our provider's mind. They're thinking more mental health diagnoses. Ruben can work with this person's trauma, depression, anxiety, but not so much that we can do much more than that. We can help a patient adhere better to CPAP. We can do a lot of the other factors, teaching assertive communication skills, a lot of other things that are more health related, more health behavior change related. I don't think that that is always in the forefront of many of providers' minds. And so that's an ongoing process where I become very happy when someone tells me, Ruben, this person is needing to best adhere to medications. We can go in there and we can really help a patient with that. And that may not necessarily be a patient with any mental health challenges. It's just we're having an issue with medication adherence. And so we can do that. And I don't think that a lot of times our providers think of our skill set being something that can be used for those presentations.
Thank you. Very helpful.
I have a question for you. I
Sure.
want to thank you for sharing a lot of the resources that you
Yeah.
did. I did not know there was a Headspace channel on Netflix. I've used their app before and really liked the app, so we will check that out. But with when I was talking with you earlier about our comprehensive cancer control grant, the Centers for Disease Control and Prevention, which funds that program, cancer survivorship and quality of life and supporting cancer survivors is a very important component of that program. And in fact, for this current year, they provided we could apply for supplemental funds to help increase group psychosocial support networks in the state. So what we did through the coalition, we turned around and we offered a small grants application process to be able to fund groups to either create new or expand existing support groups that they had. And so this is a question, we just funded them. I invited them to come on, and somebody who couldn't did have a question, and I wanted to ask that question of you. The question that they have is the question of, is it advisable with support groups to maybe have specialized tracks or sessions, for example, something that is only for patients who might be within the first year of their diagnosis. So, compared to, being just in an overall general group where you could be in with patients with all different kinds of cancers and anywhere along the continuum of their journey.
My thought there is that I think that opening it up to everyone would be what I would prefer to go with, because I think the utility of a group is that you hear things from other people that really give you a very unique perspective. I think every one of us here in this call is going to have our own level of skill set, and our message is going to be received in a particular way. Like my message as a psychologist is a very important one. But I'm imagining that someone who's been through cancer multiple times and what they would say to someone who's just newly diagnosed would be a unique and very powerful message. And so allowing for those opportunities, I think, really is the most amazing part of group therapy. And that, of course, is very dependent on who the participants are, how open they are to disclose. And so over time, groups become a bit more comfortable with each other. But I think that it can really be helpful to have that continuum and that diversity in ages and backgrounds. I can, of course, see scenarios where that may not necessarily always be the best. But I think overall, having a diverse set of experiences and people could add to the perspectives and the messages that they are each going to be giving to each other. Because group therapy works best when the therapist actually takes a step back and just lets the group really talk and support one another and provide each other such unique, powerful messages of hope and resilience to one another. So my advice would be open it up and see how it goes for some time. And if needed to, you can kind of make some adjustments.
Okay, thank you. And also, I just wanted to let you know that a lot of the things that you talked about today in terms of some of the different interventions or things that can be done, when these groups, when they put forth their plan of what they're going to do with the funding that they received. So they pretty much everyone are doing a lot of these types of interventions that you recommended, meditation, incorporating some form of physical activity, nutrition, just a lot of different approaches. So it was, I really appreciate your talk today, and we'll definitely share the information with those recipients.
Absolutely. It was a pleasure to be here with everyone. And I know that everyone here is doing a lot of wonderful work for our state. And it's just very humbling to be in a group of such caring people that are looking for different ways to help our population. So I thank you all for the opportunity to be here and for what you are all doing for our state.
And do we have any other questions from any of the other participants? Courtney, I see you raised your hand.
Kind of to piggyback off of what Susan had mentioned, do you feel that it would be helpful, even if the patient doesn't have a history of depression or anxiety or whatnot, would it be helpful for in that initial diagnosis to do kind of like the baseline like depression scale test or screening, and then kind of follow that and do one once a month, once every couple months, just to see where they're at?
Absolutely. I think making it a routine, kind of formal and informal, or more in the kind of more standardized PHQ-9, GAD-7 sort of way. And then just also like, how are you doing with all of this? So kind of both would be very valuable. I think when it comes to cancer diagnoses, there may be just a sense of, I can't do anything about this anymore. I mean, it's just sort of like, I'm hoping that my medical team can help me here. And so I think even talking to those patients and saying, actually, there's a lot you can do. Rally the people around you. Try to start to make small steps towards building these habits that are going to be helpful for you, can help with things that can get your mind to engage in something different, like go cook something consistently twice a week that is going to be healthy and good for you, and dive into the 5 sensory experience of the whole thing. That's a behavioral activation, helpful thing to share with other people, and to then introduce some good nutritious food into your body. And so thinking about really promoting that sense of, I can do something in response to my cancer diagnosis, would be helpful from the very get-go, no matter where a patient falls in that continuum that I described. But certainly if they're having more concerns, it would be important to monitor that. And I like that the PHQ-9 can also highlight elements of potential suicidality that may warrant more targeted assessment and intervention. So absolutely consistent assessment of patients would be something I would highly recommend. Any other questions from folks?
if there's no other questions, we'll have Jenny put up the post-test poll and ask you to fill that out. And while she is getting that up, I will just quickly announce our next session is going to be on October 24th. Dr. Catherine Moffat is going to be talking with us about HPV vaccination outreach for providers. And that will actually be our last session for 2023. We don't offer sessions in November or December. So we look forward to seeing you next month. And Jenny, do we still need to keep the poll up, or are we good?
Just another couple seconds, I think.
Okay.
All right, I think we're good.
Okay. Well, thank you all for joining us today. And as I said, we will follow up and send out a PDF of the slide presentation and any other information from today's session. So we thank you. Enjoy the rest of your day.
All right, thank